Module 3M. Symptoms. Malignant pleural effusions. Malignant pleural effusions. Definition. Fluid accumulation in the potential space between the visceral, inner, layer covering the lungs and the parietal, outer, layer covering the chest wall. Malignant pleural effusions. Symptoms. Dyspnea, cough, chest pain, decreased mobility and fear. Overview. Scope of the problem. Causes. Pathophysiology. Diagnosis. Prognosis. Management options. Treatment strategies. Impact. More than 25% of newly diagnosed pleural effusions are due to malignancy. 50% of cancer patients will develop a pleural effusion in US. Approximately 100,000 malignant effusions occur. Life expectancy 4 to 12 months. Causes. Breast and lung cancer 50 to 65%. Lymphoma, GU, GI 25%. Unknown primary 7 to 15%. Prognosis. Mortality 54% at 1 month, 84% at 6 months. Survival about 10 months. Where pleural effusion is first evidence of cancer known. CA, exudate, negative cytology. Poor prognosis compared with positive cytology. Role of pH. Karnofsky Performance Scale. Key points. Pathophysiology. Assessment. Management. Pathophysiology. Normally pleural fluid production equals fluid resorption. Effusion. Imbalance between fluid production and resorption causes. Tumor cells blocking lymphatic drainage. Changes in colloid osmotic pressure due to hypoalbuminemia. Assessment. History of dyspnea, chest pain, cough. Physical examination of decreased breath sounds, dullness to percussion. Assessment. Symptoms. Dyspnea, dry cough, pleuritic pain, chest discomfort, limited exercise tolerance. Exam. Decreased breath sounds, dullness to auscultation and percussion. Chest X-ray PA, lateral, and decubitus films. Chest CT or ultrasound if loculated. Differential diagnosis. Parapneumonic effusion, emphysema, chylothorax, transudates. Benign versus malignant effusions. S criteria for exudates. One or more of following. Pleural fluid LDH divided by serum LDH is greater than 0.6. Pleural fluid protein divided by serum protein is greater than 0.5. Pleural fluid LDH is greater than 2/3 upper limit of normal, ULN, of serum LDH. Benign versus malignant effusions. Hefner meta-analysis for exudates. Pleural LDH is greater than 0.45 ULN. Pleural cholesterol is greater than 45 mg per do. Pleural protein is greater than 2.9 g per do. Benign versus malignant effusions. Cytology. Positive for cancer in approximately 55 to 65%. Initially yield up to 77% positive on 3 pleural fluid samples. Management options. Thoracentesis, tube thoracostomy, small bore chest tubes, pleurodesis, thoracoscopy, intrapleural catheters, pleuroperitoneal shunting, subcutaneous access ports. Thoracentesis, diagnostic, therapeutic, temporary relief, many contraindications, risks, pneumothorax, re-expansion pulmonary edema, especially if more than 1,500 cc removed. Treatment recommendations. Thoracentesis, diagnosis, palliation until more definitive procedure, medically ill, short life expectancy. Tube thoracostomy, free-flowing effusions, unable to tolerate general anesthesia. Thoracoscopy, life expectancy greater than 3 months. Loculated effusions, biopsies. Intrapleural catheters, outpatient pleurodesis. Thoracoscopy benefits. direct visualization of lung re-expansion, identify loculated areas and drain, administration of dry talc, chest tube placement, confirm equal distribution of talc, shorter hospital stay than tube thoracostomy, diagnostic yield 90%, pleurodesis success rate 90%. Tube thoracostomy and pleurodesis. More definitive than repeated thoracentesis for recurrent effusions, chest tube 12 to 24 hours or until drainage is less than 250 ml per 24 hr. Tube thoracostomy and pleurodesis. Sclerosing agent. Use after fluid completely drained from pleural space, talc, bleomycin, doxycycline. Tube clamping controversial. Rotation versus non-rotation. Failure rate 10 to 40%. Most widely used and cost-effective method. Summary. Use comprehensive assessment and pathophysiology-based therapy to treat the cause and improve the cancer experience,